today I'm going to be talking about advances in surgical cancer care and what cytoreductive surgery and HIPEC really is. Like Glenn said, I'm Samantha Ruff. I'm one of the surgical oncologists at the University of Virginia. I actually started the HIPEC program here when I was hired about a year and a half ago. So metastatic cancer is a cancer that has spread from the original location, like the colon, to a separate location, often the liver, the lungs, the lymph nodes. Another place that it can often spread is what's called the peritoneum. The peritoneum is the lining of your abdominal wall. And this lining of the abdominal wall then also coats a lot of the organs. So you can see there in red on the photo, that's the lining. And then on blue is it's coating all of your organs. I often think of it like saran wrap. Like if you think about your organs having this thin layer of cells on top of it, that just helps them from sticking to each other. And so a lot of these metastatic nodules can land onto that saran wrap that's in your abdomen. While this can represent a poor prognosis for patients with metastatic cancer, cytoreductive surgery and HIPEC, which is hyperthermic intraperitoneal chemotherapy, can be a beneficial treatment and be able to give patients more time and good quality time. When you're looking at peritoneal disease and we're looking at a CAT scan, what you're looking for is these little discrete nodules, which can often be difficult to see on imaging. So sometimes and often there's a lot more disease in the abdomen than what we see in the pictures. But just as an example here, you can see the yellow arrows are pointing to what's called the omentum. So this is a fatty curtain that lays in your abdomen and helps protect a lot of your organs. And this is often one of the most common places to see peritoneal disease. Now, when you're looking at a CAT scan, just to orient you a little bit, your feet are coming out of the screen, your head is going into the screen, and you're lying on your back, and then it slices you into individual cuts. And so bright white, like that, is the spine, is bone, and these are your ribs. And then black is air, so you can't see it in this photo, but that would be like lungs. And then you can see those omental nodules with the yellow. Now you can also look on this other photo, this is your liver here on the right side, and you can see that instead of a nice smooth edge where it's touching the abdominal wall, there's all this gray around it, and that's all disease. This is another example, maybe a less extreme CT scan, where you can just see the little discrete nodules that the yellow arrows are pointing at. And so when we're looking at imaging, we're looking for these nodules in different places in the abdomen to kind of guide where the disease might be and where we can get biopsies and what might need to be treated during the operation. This is what it looks like on the inside. So it's often these little bitty discrete couple millimeter in size nodules that are lining the abdominal wall. You can see these tumor deposits in different places. So when we think about cancer treatment, we can often split it into two different categories. One is local regional therapies, and the other is systemic therapies. Local regional therapies are treatments like radiation therapy, surgery, and they are really focusing on treating one part of the body or a tumor or one specific area. A systemic therapy, an example would be chemotherapy, immunotherapy, hormone therapy, targeted therapy. These are medications that are given either in the IV or as a pill. And these medications don't just treat one spot. The goal is that they treat the entire body. So they treat the disease, the tumor that you see, but also all the disease that you can't see, all the tiny little microscopic cells that have been traveling throughout your body that have broken off from the original cancer. Cytoreduction surgery and hyperthermic intraperitoneal chemotherapy, or HIPEC, is a form of localized therapy. We're just treating the abdomen. The chemotherapy doesn't treat the entire body, it just treats the cells in the abdomen. So when we think about how this works, I like to describe it as your abdomen is a garden. So when we go into the garden, I'm removing all the visible tumor. I'm trying to pull out all the weeds. And then once I've removed all of that tumor, I'm giving chemotherapy, which can often act like a weed killer. So we're trying to treat all the stuff that we can't see, all those little bitty cells. So the goal is that by combining these two approaches, we can make it so that the disease doesn't come back. The procedure is all done on the same day, and it's all done in the operating room. So we remove all the visible tumor, do usually about 90 minutes of chemotherapy perfusing through the abdomen and washing through the abdomen, and then wash out the chemotherapy, and finish closing and making sure everything's okay before we finish in the operating room. I thought it'd be interesting just to kind of go through a little bit of the history of HIPEC and cytoreductive surgery as well. So the use of heat to kill cancer cells actually dates all the way back to the Egyptians in 5000 BC. They found that if they burned tumors on the skin, that sometimes the tumors did not come back. And all the way dating back to the 1930s, tumor debulking was first described for ovarian cancer. And that's where a lot of the debulking operations really started to take off, was for ovarian cancer. In 1980, Dr. Spratt was one of the first to introduce the idea of HIPEC. And he actually treated patients with heat and chemotherapy using a perfusion device. And this showed that the control of cancer was best achieved through a combination of not just heated perfusion, but also with chemotherapy. In the 1980s and 90s, Dr. Sugarbaker, who's a very famous surgeon, often considered the kind of father of modern day HIPEC, started to explore this outside of ovarian cancer and started to look in GI cancers. He started with gastric, but then we expanded it to different cancer types, like stomach or colon. He developed ways to score the abdomen and to be able to communicate between surgeons about the burden of disease. And he also went on to publish several papers on how to do what's called a peritonectomy, removing that saran wrap or lining of the abdominal wall in order to remove the bulk of the tumor. And then now, really research is focused on identifying which patients will derive the greatest benefit from this type of treatment through clinical trials, lab work, retrospective studies, all focused on reviewing charts in order to both expand who we can use this treatment for, but also narrow down the window of who's going to derive the most cancer benefit from it. This is a picture of the actual machine from Thermo Solutions that we use here at UVA. It's also the one that a lot of the centers around the country use. The chemotherapy is put into this pump, and then the cannulas are hooked up into the abdomen. The abdomen is temporarily closed, and then the chemotherapy is perfused through the abdomen at 1.5 liters per minute. This occurs for 90 minutes. There are a lot of benefits of heating the chemotherapy. So it's not just that we're giving chemotherapy into the abdomen, but also that we're trying to have some benefit from it. So the heat can directly kill cancer cells. It can make so the heat directly kills the cancer cells. The second thing that it does is that the heat can make the chemotherapy work better. So it might actually improve the sensitivity and the ability of the chemotherapy to work and to be able to kill cancer cells. And the third is that it really can activate the immune system. And so it's revving up your immune system while putting the chemotherapy in there and trying to get the immune system to attack those cancer cells that exist. The chemotherapy is heated to 42 degrees Celsius. And it's kind of kept at that temperature for the whole 90 minutes. So who do we treat with this? So like I said, the most recent research is about expanding the criteria of who would benefit from this operation while also narrowing who derives the most benefit. So the most common things are appendix cancer, colorectal cancer, ovarian cancer, and then there are some very select scenarios where this can work for stomach or gastric cancer. There's also another type of cancer called mesothelioma, and this is a cancer in the lining of the abdominal wall. So instead of this being a cancer that started somewhere like the colon and spread to the peritoneum, it's actually a cancer that originated in the peritoneum, the lining of the abdominal wall, and grows throughout. And so this can be very difficult to treat because if we think about peritoneum, it's not just the lining of the abdominal wall, but it coats all of our organs. And so cytoreduction surgery and HIPEC for a lot of these patients has shown to be really beneficial. So the next question really becomes, how do we decide who is a good candidate for this? And that comes down to several things. So first is looking at, these are big operations that take all day. The peritoneum covers everything in the abdomen. And what do we want to do? And so we think about this first as the disease burden. So when we're looking in the abdomen, how much disease is there and can I remove all of the disease? When I'm thinking about how much disease there is, I use a scoring system. And so that's called the Peritoneal Cancer Index score. It splits your abdomen up into a tic-tac-toe board with 9 different sections. And then there is 4 more sections for the small bowel. So it's 13 sections total. Each get a score of 0 to 3 based on the size of the tumor that's in there. So when we're assessing the disease burden, we want to know what that PCI score is. It's a way for the surgeons and different physicians to communicate with each other, but it also is something that we use in clinical trials and in studies to try and figure out what number is too high for different cancer types. So for example, for colon cancer, most people are comfortable doing site reduction surgery HIPEC up to a score of a 25 or 26. But we know that above that, we might not derive the same benefit as we do when the score is lower. But gastric cancer, that score needs to be closer to a 7 to 10. And so based on the cancer type is how we decide what score patients might derive a benefit. The second thing is whether we can remove all the disease. So if I can't remove all the disease, if I can't pull all the weeds out of the garden, then giving the chemotherapy is not going to help, because the chemotherapy really only penetrates 1 to 2 millimeters. So it's really meant to treat really, really, really small nodules or disease that we can't see, just individual cells or cell clusters. And so most of the time, there's a lot of things that we can remove. I can remove gallbladders, we can remove small pieces of the liver, the spleen, pieces of bowel. But there are 2 areas that are big stopping points for surgeons. One is the small bowel. We can remove a lot of the individual tumors off the blood supply to the small bowel, but we can't remove all of your small bowel because you would end up with what's called short gut syndrome. Short gut syndrome leads to poor nutrition, poor quality of life. And I would say the other major stopping point is the inflow to the liver. And what I mean by that is the blood supply to the liver. So we can take all of the tissue that surrounds that area, but we can't take the actual inflow to the liver, or else the liver wouldn't be able to get oxygen and nutrients and be able to work as a filter for our body. So we think about how much disease is there and does it make sense for the cancer type? Where is the disease and can I remove it all? And then we think about the location of the cancer, so colon versus rectum versus mesothelioma or appendix, all changes how we make those decisions. And then it's really about whether you can tolerate the surgery. So are your heart and lungs in good enough shape? Now these are operations are anywhere from 10 to 14, 15 hours sometimes. They're all day surgeries. It takes a long time to remove all the visible tumor and then to give the chemotherapy. So we want to make sure that you can tolerate the anesthesia, that you can recover from it. If we're giving all these high risks without that benefit, then we worry about not being able to derive the benefit and be able to live longer and also have good quality of life. There's still a lot we don't know about metastatic cancer to the peritoneum. So while we know that cancer spreads to the liver or the lungs and does so through the bloodstream or the lymph nodes, we don't really know why cancer spreads to the lining of our abdominal wall or to the peritoneum. There are several theories. One of the theories is that the cancer cells are able to somehow escape. Like let's say we're in the colon, they're able to escape not from the inside of the colon and be able to kind of work their way through the wall somehow, migrate and just kind of circulate in the abdomen rather than traveling through the lymph nodes, and then be able to land somewhere, to change the environment around it and be able to develop into larger tumors that we can see on imaging or with our naked eye. Other theories are that when you have a tumor that maybe has perforated, meaning like if there was a tumor in your bowel and it led to spillage into the abdomen, or there was a hole in the bowel as a result, that might be another way that the cells are able to escape. So for most of the time, we think that somehow the cells are able to escape, they're able to land somewhere else, develop into a larger tumor by changing the way the immune system and the environment responds to it. But we don't really know the exact mechanism or steps for how that happens. It's where a lot of the research is being done. Part of what I do here at UVA is I run a lab studying metastatic colorectal cancer to the liver and then also to the peritoneum, and my goal is to try and better understand how the environment shapes how the cancer cells grow in other places, and then being able to use that information to develop new treatments, new targeted therapies, new immunotherapy combinations, all with the goal of trying to treat the metastatic cancer. we're thinking about cytoreduction surgery in HIPEC, I think a couple important takeaways is that this is cancer that is spread from its original site to other parts of the body. When it does spread to the abdominal wall, one of our many treatment options is cytoreduction surgery in HIPEC to try and remove and treat all of the disease. But this is not something that we do by itself. We don't just do the surgery. We want to include things like chemotherapy, immunotherapy, and other systemic therapies, targeted therapy, all to try and have a combination of treating the abdomen and preventing it from spreading somewhere else, like the lungs or the lymph nodes or the liver. In cytoreduction surgery, like I said before, I'm pulling all the weeds out of the garden, I'm getting all the visible tumor out, and then I'm circulating heated chemotherapy in the abdomen, all with the goal of being able to get the disease that we can't see. And then, I think this type of operation, it's a big surgery and there's real risk involved, but it really is something that can benefit and make a difference in a lot of cancer patients' lives. And it does so by being able to essentially reset the clock. So if we can get through chemotherapy, not have disease progression, and then be able to do this big operation and do well with it and minimize complications, then we can really make a difference in resetting the clock, getting patients back to not having disease that we can see, and getting them off chemotherapy and back to living their lives. And so I do think that it makes a huge difference for a lot of patients. And the great thing about it is that we're still learning about how to choose who should benefit from this operation, and we're still using all these opportunities to do research to try and better understand how cancer spreads so that we can develop new treatments. Yeah, so I recommend that patients meet me in the beginning. I think that cancer care in general is better done when it's a multidisciplinary team, and you want medical oncologists, surgeons, radiation therapists, radiologists, pathologists, interventional radiology. There's a huge team that takes care of you when you have cancer. And there's usually a couple of captains or quarterbacks, and that depends on what we're doing. So when the chemotherapy part's happening, then the medical oncologist is usually in charge. And when we're doing surgery, then the surgeon is often in charge. But we work together really closely. And I think it's nice, because this is a big operation, to be able to meet the surgeon early in your diagnosis. It lets you get kind of an overview of what the next several months might look like while you're on chemotherapy. How do we decide surgery? It lets you get used to the idea of what this big operation might mean. And it also just answers a lot of questions, I think, about when we make decisions and how we're going to make decisions. And so I think meeting most of your team up front, especially really the medical oncologist, and meeting a surgeon, just gives you time to process everything that's going on, lays out a little bit of a roadmap, and so you kind of know where the check-in points are and when we're going to make the big decisions. So there's a couple ways. Most of the time it's done on imaging. Some patients will have no symptoms sometimes, and it's just seen when they do surveillance imaging. I've had patients who were on surveillance, meaning they finished their chemotherapy, finished their surgery, were told they have no evidence of disease, and then either their tumor marker in the bloodstream or like a ctDNA test, like something was elevated that had not been elevated before. And so they got a new imaging, and they were able to kind of note like, oh, there might be some haziness there. Now, sometimes it can be hard to see on imaging, and if there's a question about something being peritoneal disease, I will often recommend doing a diagnostic laparoscopy, which is where we put a camera inside the abdomen, look around, and see if we can biopsy something that's there. If we can see something on imaging and we know that that's most likely what it is, we can often do a biopsy with a needle from the outside, not need to go through the small operation, and be able to get a diagnosis that way. So most of the time, it's either seen on imaging when you're getting your surveillance checks after completing treatment, seen on imaging just at the time of diagnosis, or your tumor markers in the blood get elevated, and that kind of sets off an alarm bell that maybe we're not seeing something on imaging that we expected to see. And so that can have us look a little bit deeper and a little bit closer, and sometimes put a camera in to take a look. That's a great question. I usually tell patients it's about 7 to 10 days in the hospital. The main rate limiting step with going home from this operation is that your bowels take a long time to wake up, because we operate on the bowels. The chemotherapy it is causing the bowels to be a little sleepy. It's a long case with a lot of anesthesia, and that can make the bowels be sleepy. And so once your bowels are a little more awake and you're passing gas and having bowel movements, it's much easier to advance your diet. We can switch over from different kinds of pain meds to oral pill pain meds. And so a lot of that 7 to 10 days is about making sure you're eating and drinking well, your bowels are working and your GI tract is functioning, that your pain is well controlled, and that you're getting up and walking around. So the goal is always that you go home and you're kind of doing your normal activities. Now, I would say it's about 2 months for patients to really feel like themselves. And what I mean by that is that during those 2 months, you will gradually see improvements, but a lot of times you're more fatigued. So you might need a nap in the afternoon, or maybe you used to be able to walk 2 miles, no problem. That was your daily walk. And now you walk less than that, but you could take more shorter walks. You have to kind of build that endurance back up a little bit. And then the second thing is people tend to have a low appetite. And that's just because of all the work that was done in the abdomen, but that appetite does come back. It just takes time. And so usually those first 2 months to really bounce back, but it's not the whole 2 months you're feeling tired with a low appetite. It gradually improves over time. Yeah, also another great question. So in addition to, I talked about metastatic cancer, but there's also certain appendix tumors that do not respond to chemotherapy, like low-grade or high-grade appendiceal mucinous neoplasms. You might have heard them called Lammin or Hammond if you Google them. So there's different scenarios where I would repeat a HIPEC. For Lammin or Hammond, those appendiceal mucinous neoplasms, they don't respond to chemotherapy. They don't spread to your liver and lungs the way a traditional cancer would. They really just spread to the peritoneum. So a lot of times we surveil those patients after cytoreduction surgery HIPEC, because that's the main treatment for them. And we're watching them over time. And if the disease comes back, it's not like we jump right in and let's do another big surgery, but we watch it over time. If the disease is growing, then yes, we will repeat cytoreduction surgery HIPEC for those patients. I would say for metastatic cancer like colon, rectum, ovarian, sometimes gastric, but not quite as much, to be honest. And then for primary peritoneal cancer or mesothelioma, those are scenarios where we have to be thoughtful about when we repeat it. Yes, you can have a disease recurrence after getting cytoreduction surgery and HIPEC, and that's part of the research, right? Is trying to predict which patients are not going to have recurrence and which ones are, so that we can figure out who's going to benefit the most from this operation, while also trying to improve all the therapies that you get in the IV. For some of those select scenarios, we will repeat cytoreduction surgery HIPEC, and that comes down to a few factors. So for me, it comes down to how long has it been since you had your first surgery? Has it been a really long time and it's been 4 or 5 years and this is now new disease? Because that to me means, okay, we got a lot of benefit out of that first surgery. Maybe we can get benefit from the second. Now, if the disease comes back in a really short amount of time, like a year or 6 months, I wouldn't jump into doing another big operation because I'm not sure how much benefit you'll really get from it. So a lot of when we decide whether or not to repeat a surgery is based on how the tumor is behaving and how you've responded to other therapies. I think in terms of what we're doing next in this field, there are people doing clinical trials for different types of tumors. Like there is a clinical trial, I think, for pancreas cancer going on. I don't know the data coming out of it yet because it hasn't been published. I think gastric cancer is a big area where they're still doing it, because right now we only do it for gastric cancer with people who have really, really low burden of disease. And so they're trying to figure out if we can expand that criteria. I think another area of interest, I'm sure people have heard about HIPEC or pressurized intraperitoneal chemotherapy. And so this is giving aerosolized version of chemo, and that's still being done on clinical trial and trying to figure out what patients might benefit from that rather than giving it as a liquid, giving it as a gas. I think also, so there are other areas where we might not use HIPEC, the chemotherapy part, but we are deciding whether debulking or cytoreduction surgery works for patients. So things like neuroendocrine tumors, different types of sarcomas where it might be beneficial to go in and remove all the visible tumor, but we're not giving chemotherapy afterwards. Once again, I'm Samantha Ruff. I'm at the University of Virginia. Thank you so much for having me.